To the next talk. It is VA ECMO. It is a complete session in itself, very difficult to cover in 20 minutes. So parts of VA ECMO are covered elsewhere, like the ECMO physiology, the cannulation part, the anticoagulation part, complications, cardiac stunning, which will be taken subsequently. So I will only discuss about the indications, advantages, disadvantages, monitoring, management, weaning and complications. There are no financial sponsorships. As you all know, VA ECMO is blood drained through a vein and oxygenated and reinfused back into the artery. So I will be taking that aspect of ECMO, that is VA ECMO. As you very well know, from 1975 onwards to 2000, it was mainly a pediatric and VA ECMO era. Then from 2000 to 2010, it was more of a VV ECMO and gradually transitioned to adult respiratory ECMO. From 2010 to 2020, gradually, as people started taking more challenges, it again went to an adult VA ECMO or the cardiac ECMO. So there has been a constant swing over as we improved our understanding about ECMO. What is VA ECMO? VA ECMO is basically a support to a dysfunctional myocardium. Myocardial dysfunction is because of an inflammatory response, myocardial ischemia, hypothermia, reperfusion injury, inadequate myocardial protection, or ventriculotomy. Causes of myocardial unhappiness, surgery, or medical conditions. In medical conditions, myocarditis, cardiomyopathies, dysarrhythmias, drug effects, transplant rejections, sepsis, and metabolic diseases. We require a VA ECMO for basically a short-term or a long-term support. Short-term support for less than 30 days, long-term support by other mechanical circulatory devices. There are other types of short-term devices also. The indications of a mechanical support is the bridge to recovery, which is a potentially reversible potentially reversible myocardial dysfunction, or a bridge to transpel for an irreversible dysfunction of the myocardium, or a peri, or post-operative stabilization of a dysfunctional heart. But there are two important parameters, that it is a potentially reversible condition and there are no absolute contraindications for support. Indications for emergency mechanical support like cardiopulmonary resuscitation, severe pulmonary hypertension, malignant dysarrhythmias, or emergency situations like salvage situation of high catecholamine demand, low cardiac output in OTs and cardiac cath labs. Miscellaneous indications are tracheal reconstructions, myocardial trauma, hypothermia, sepsis, poisoning, non-beating heart, organ donation. And recent admission has been in emergency situations in cath lab in acute MI and in cardiogenic shock. The indications for VA ECMO are as per parameters: and a cardiac index of less than 2 liters per minute for more than 3 hours, metabolic acid with a acidosis with a Bates deficit of more than 5 for more than 3 hours, blood pressure, mean arterial adult pressure of less than 60 and less than 40 in neonates, and after a technically satisfactory repair but failure to wean off. Contraindications are possible or a major brain injury, prolonged shock, that means severe metabolic acidosis and oliguria, and after a technically unsatisfactory repair. What is the effect of VA ECMO on the body? It decreases the preload, it increases the afterload, it increases the systemic blood flow, it decreases the pulmonary blood flow, and there is a differential hypoxia or circulation and left heart stasis. What are the advantages of VA ECMO? It is easy to use, there is a circulatory and a respiratory support, the instant hemodynamic stability and no recirculation. But the disadvantages are it involves the cannulation of a major artery with lack of pulmonary perfusion, decreased cardiac output, coronary arteries are at a receiving end, non-pulsatile flow, left ventricular distension, cardiac stun, possibility of emboli to arterial side, and increased risk of neurological episodes. There is always a final deciding line with all these inotropes, with this point of scoring system. If the score exceeds 20, we advocate a VA ECMO, but in India, even at the score of 40, we don't even think of ECMO. And I've seen centers, they even wait up to 80-point score. So that is the result of failure of a VA ECMO, because by the time the chemical damage to the heart is already taken place. This is a simple circuit of a VA ECMO, draining cannula, the pump, the pre-pump pressures, oxygenator, and the oxygen supply to this, and the arterial return to an arterial line. Cannulation will be covered later down in another topic, but can be placed by both on Seldinger technique and by an open technique. The inflow cannula advances to the right atrium, the outflow cannula is into the femoral artery, which is to supply the aorta, and the distal limb must be perfused. So this is the important part of the circuit. We have to take care of the antegrade distal limb perfusion, otherwise limb ischemia is an important complication. These are the cannulas of the ECMO: arterial side 7 to 21 French, venous side 23 to 25 French. The pressures on the return cannula should remain not less than 60, and the pressure on the drainage cannula should remain less than 300. So these are the end points of the pressure in the cannula. The cannulation side can be central or peripheral. In peripheral, it is veno-arterial at the femoral side, and central it is from the right atrium or from the left atrium into the aorta. This is just a picture to show how to obtain an hemostasis after a central cannulation. To start with ECMO, we have to look at the circuit, we have to look at the cannulation, hyperonization, initiation of therapy, and lung management. ICU management of ECMO, the ECMO and the patient hemodynamics, ECMO and the patient's gas exchange, radiology aspects, echocardiography aspects, and other ICU care like ventilators, inotrope, sedation, nutrition, infection, bleeding, thrombosis, etc. Now to focus on monitoring, we have to look at three aspects: the accuracy, efficacy, and the safety. The accuracy and the efficacy is on the part of the machine, and the safety is on part of the patient. For accuracy, we have to check the circuit hourly. We have to see the machine in terms of the blood flow rate, the gas flow rate, the revolutions per minute, the ECMO FiO2, on the oxygenator part, the delta pressure, and the post-membrane gas pressures. Efficacy can be assessed by the clinical and the biochemical parameters. The goal is to maintain adequate tissue perfusion with minimal complications. And for this, the mean arterial pressure has to be 60 to 80, mixed venous oxygen saturation to be 70, lactates less than 4, and the cardiac output more than 2.5. In the safety, there is ECMO parameters, coagulation status, the hematological status, the biochemical status, and to monitor things on clinical radiology, echo, and cardiac output. So there are various pressure lines, there are various biochemical parameters and coagulation parameters on which we assess the safety of the ECMO run. We also see the ECMO run on the console. There are few important parameters on the console, like the pump pressure, the venous pressure, the arterial pressure, the pump speed, and the SVO2. Then we require patient percutaneous parameters like CO2 and SpO2 monitoring, and a constant display about online monitoring of all the parameters and recording of all the parameters. Then to see the ECMO flow and the ECMO speed. At the same ECMO flow, at the same ECMO speed, you may find a different ECMO flows depending upon the afterload and depending on the preload. So therefore, there are even instantaneous variation because of sudden spasm of the venous cannula or the IVC on the venous cannula. So these things has to be constantly monitored and they has to be prevented. If to increase the ECMO flow, you have to increase the preload, decrease the afterload, and to decrease the contractility, and vice versa. There are three important pressure lines on an ECMO circuit: the P1, P2, and the P3. P1 is pre-pump, the P2 is post-pump or pre-oxygenator, and the P3 is post-oxygenator. That is the important parameters on the circuit. With the various changes in P1, P2, P3 determines and helps to tell you what is happening to the patient. So all these three pressures has to be constantly monitored and analyzed. The gas flow, the oxygen versus the air through a blender. So you have to control the sweep gas to control the carbon dioxide and FiO2 to control the oxygen levels. And the oxygenator, you have to see the venous and the arterial side to look for fibrins and clot deposition. You have to monitor the end tidal carbon dioxide for weaning purposes. Then monitoring of the patient. Monitoring the patient parameters, the ECG, pulse, invasive arterial blood pressure monitoring, the filling pressures, the temperature, respiratory rate, and the urine output. Then gas exchange and tissue perfusion. SpO2 is flow dependent. SvCO2 is the target is around 70 to 75%. Lactate levels, cerebral perfusions, and capnography. What is the ventilatory management? The goal is to give rest to the lungs and avoid lung collapse. For this, you have to keep at a rest ventilator settings with a low rate, low inspiratory time, low tidal volume, low plateau inspiratory pressures, low FiO2 and low PEEP. And you have to maintain the pulmonary toilet. Ultimate goal is to extubate the patient and manage an awake ECMO with spontaneous breathing. And also to look into coronary perfusion, if required, bronchoscopy, HFOV and nitric oxide. Fluid and electrolyte management, you have to, it is to be constantly seen. You have to increase the circulatory volume, look into SIRS and see the renal functions. Look for fluid overload, look for electrolyte imbalances, particularly hypocalcemia and hyperkalemia, and assess the fluid status with ECO, the SVV, the fluid response to fluid challenges, and the pre-membrane pressures. Then the management of fluid balance is to keep the patient as dry as possible, aggressive diuretic therapy, and early CVVH. If there is a chartering of the venous return cannula, you have to adjust the RPM and versus the volume of the patient infused to the patient. In terms of renal failure, the urine output, edema control, early CVVH, and achieve euvolemia. Sedation, it's a very important aspect. You have to do a neurological examination, avoid drowsiness of the patient, assess the pupil, and try to maintain an awake ECMO. Nutrition, the most important is as soon as possible. So try to have a rice stew feeding and maintain the calorie and the protein supplement and enteral nutrition with constant blood sugar and protein management and bowel regimens. The hemodynamic management of hypotension during ECMO, the possible causes are inadequate preload, low hemoglobin, loss of pulsality. So therefore you maintain the preload, correct hemoglobin, and occasionally vasodilatory shock requires a vasopressors. Then inotropes usually weaned off after ECMO initiation. Some background inotrope may be required to maintain the contractility. IBP is also helpful. ECMO and infection, this is a separate topic, but that is a necessary evil attached with ECMO. So all the time, the counts, the CRP, the PCTs, the blood cultures, the tracheal aspirate, urine samples, and examination of the cannulation sites. ECMO and hemolysis look for urine color, red blood cell count, plasma-free hemoglobin, serum lactates, bilirubin, hemoglobinuria, and kidney functions. ECMO biological monitoring, you look for the arterial and venous blood gases, the lactates, the hemoglobin, the hematocrit, white blood cells, platelet count, renal and liver functions, and the coagulation parameters. The complications of ECMO, the medical complications, ECMO-related complications, and mechanical complications. They are common, and the treatment path and the cause has to be analyzed. Then special problems during VA ECMO, there are mainly four. There is a differential circulation, there is myocardial stunning, there is a left heart stasis, and limb ischemia. Both myocardial stunning and left heart stasis I would cover in the separate talk. I will talk about limb ischemia and different ischemia. Limb ischemia is a very important complication. Causes are arterial embolism, hematoma compression, femoral arterial cannula is too large, coronary arterial vessel spasm. What you require is a clinical and a vascular Doppler monitoring. Management is through a distal perfusion and surgical intervention if required. This is how you start getting the bluish discoloration of the digits, and then slowly edema and blisters on the skin, and then pre-gangrenous setting can start occurring. So for that you require a antegrade return cannula on the antegrade side where the arterial cannula has been put to perfuse the same limb ipsilaterally to prevent limb ischemia. So this is what you see, that this is the lead lock of the arterial cannula. You use a 7 French or a 8 French cannula which is put back into the same side artery, and some amount of blood goes from here into the return this perfusion cannula to supply blood to the ipsilateral limb. This is just a picture to show you the same. Again the same thing. And the second thing is competitive flow. The competitive flow is also known as Harlequin syndrome. It is common with VA ECMO. As the LV function improves, then the upper part of the body is perfused by the deoxygenated blood from the LV, and the lower part is perfused by the well oxygenated blood from the ECMO. So therefore this is a time to switch over from VA ECMO to VV ECMO, but it has still a time to go. Basically it is a competition in the aorta, flow competition in the aorta. If the pulmonary function is impaired, then the deoxygenated blood is directed to the upper part of the body and hyperoxygenated blood is to the lower part of the body, and therefore you switch over to VV ECMO if persistent lung failure occurs, or VAV ECMO. And this is just to show you the picture. You see if the left ventricular function is picking up, you can start thinking of weaning off all the patient also. Then monitoring and management of upper limb body hypoxemia. You improving cardiac function with poor lung functioning, upper body hypoxemia, and you see the saturation on the right radial artery. Management is through ventilator setting adjustment, treatment of the etiology, axillary artery cannulation as a separate perfusion line into the ascending aorta, VAV cannulation, and converting VA ECMO to VV ECMO. This is just to show you another arterial cannula being infused from the axillary artery into the ascending aorta, so that the coronaries and the cerebrals get pure blood which is unable to come from the femoral artery cannula. Then cardiac stunning. This topic I would be covering in my second talk, but this is a very important aspect, and you require an IABP or left ventricular decompression to prevent a myocardial stunning because of over distension. So left atrial stunning, left atrial hypertension or cardiac stunning or left ventricular distension are all series of changes taking place because of over distension and dilatation of left ventricle. This is just to show you one example of a cardiac stunning. Videos. Okay, I will cover it in that second talk. V ECMO left heart stasis, left heart thrombosis, pulmonary edema, increased left ventricular wall tension and decreased coronary flow. And the method to do a LV decompression is through an IABP, impeller device, transeptal left ventricular cannulation, and atrial septostomy, or directly left ventricular apical cannulation, or LA cannulation, and non-invasively by reducing the inotrope and reducing the ECMO flow. Okay, the second topic is the cerebral hypoxia. Cerebral and coronary hypoxia is because of the deoxygenated blood going in the ascending aorta. So, what are the options? You look for an alternative method for cannulation. You look into the respiratory failure, look into the left ventricular ejection, and try to shift the hypoxic perfusion on the right side instead of the left side. So the diagnosis is by right radial saturations, and you consider the ventilatory adjustment, avoid better venous drainage and less left ventricular ejections, and VAV support, that is the partial VA and partial VV ECMO. You look for cerebral and lower limb perfusion by near infrared spectroscopy and to see the level of tissue perfusion and seeing the oxygen level at that level. These are the various circuits to be seen, for that is the treatment for a poor perfusion or cerebral hypoxia, that is basically a VAV ECMO. Then cardiac ECMO in children, it requires a lot of experience. Isolated left ventricular failure is rare, and combination of right ventricular failure, pulmonary hypertension and hypoxia is the reason for deterioration. ECMO treat all the conditions. Management in radiology is a separate topic, but I'll just show you a few pictures. Time is short, so I cannot cover them, but this is how the radiology helps in assessing and treating the patient of ECMO. Then these are all radiological pictures for helping the patient of VA ECMO and determining the condition. This is a left ventricular hypertension. You are doing a balloon atrial septostomy. Then management by the echocardiography, you monitor the cardiac function, the left ventricular distension, and you consider left ventricular venting or septostomy depending on echocardiographic parameters. So there are various things of echocardiography. This is again a separate topic in this training program. So we'll cover echocardiography in a separate talk. You see all these clots and masses only on echocardiography for VA ECMO. So successful weaning predictors are well judged by echocardiography. Then you require surveillance, because not only the patient, you have to do a presumptive and sort of a weekly exercise to understand that the ECMO is not going to create complication. So driving line surveillance, that is no folding or tension on the lines, maintain the lines along the leg axis of the patient, and there is special attention while moving the patient. Patient surveillance is to manage the lines across the leg axis from less than centimeters and check the skin aspect of the cannula at the insertion site, no bleeding, no site of skin infection. Then patient surveillance, look for leg ischemia and reperfusion. Then reperfusion line surveillance. Pump surveillance, look for any clots or micro air bubbles. Central unit surveillance to see all the parameters are running as expected. Membrane surveillance to do a daily surveillance of fibrin deposit or the clots at the oxygenator membrane. Biological surveillance of bleeding and clotting. Again, anticoagulation is a separate talk, so I will skip this aspect. Then the management of, again, bleeding and anticoagulation. This is in a separate talk, so I would just, but you have to look for clots in oxygenator. You can see a big clot of oxygen, dark brown in color in the venous side, and fibrin deposition, this yellowish in color on the venous side of the oxygenator. Then you have seen the over the time, as the number of days of ECMO run increases, thromboembolic complications are more. So what is the criteria for changing the whole extracorporeal circuit? If there are massive depositions of fibrin clots, if there is severe hypoxia, despite FiO2 set at 100% of the device, severe thrombocytopenia, massive hemolysis, membrane rupture, pump, motor or controller dysfunction, and you see if required, you may require a systematic change after every 10 to 15 days, though this may be a luxury for us, but sudden catastrophe has to be prevented. Then weaning off from VA ECMO. And weaning from VA ECMO, it requires a readiness of the center to see for patient being brought out. So see the BP, see the pulse celerity, see the right radial artery PO2 levels, look for CVP and the pulmonary artery pressures. You reduce the flows and start with trial off, and then decannulation and wound closure. So what are the weaning criteria? Daily transthoracic echo and maybe TEE evaluation. Weaning attempt of ECMO if there is no or low dose catecholamines. Post-transplantation, no RV failure. Then progressive reduction in ECMO flow rate by 66%, then 33%, then less than 10% to a minimum of 1 liter per minute. And stop if the mean arterial pressure is dropping. Then you clamp the IV lines by VAB or ABV criteria. And removal has to be in an OR where you remove the lines surgically. The trial is a frequent evaluation by the team. You trial off with using a bridge. You maintain an adequate ACT and PTT levels. You start and stop with inotrope infusion. You increase ventilator settings. You do repeated echo. and you monitor ABG and missed venous oxygen saturations. So you have got indicators for readiness of weaning, you have got prerequisites for prior to weaning, you have got stopping criteria, and you have got predictors for successful decannulation. So there are 3 stages to it. First, reducing flows by 500 ml, then second stage, reducing flows by 1 liter for 10 minutes, and stage 3, reducing flow by to 1 liter for 10 minutes, and C4, there are no stopping criteria. And then you plan for an elective decannulation. So maximizing survival on VA ECMO, good patient selection, early implementation, high flows, optimum tissue perfusion, addition of IBP, avoid leg ischemia, prevent pulmonary edema. Conclusion, the time limitation, 15 to 21 days of a time period for a VA ECMO. Patient must remain, so my local complications are hemorrhage, embolism, and acute limb ischemia. Stroke, ischemic, and hemorrhagic complication has to be monitored. Pumps are highly pre and after load dependent, and if there's a non-pulsatile flow, you have to be careful about ECMO weaning off. We always say VV ECMO is better than ECMO because the cannulation is easy. There's an effect on improvement of pulmonary blood flow. There's a decreased LV afterload, increased coronary perfusion, and there are no emboli. So even in early patients for cardiac failure, we try with VV ECMO, and if not supported, we switch over to a VA ECMO. As you see over the time period, the adult cardiac ECMO has taken a big percentage as compared to 1990, where now adult ECMO, including ECPR and pediatric ECMO and neonatal ECMO, makes more than 40% of the total ECMO run in present years. And the take-home message is that VA ECMO is the keystone of adult and pediatric cardiac ECMO. Adult cardiac ECMO is getting more and more applications. Newer applications and feature of VA ECMO is phenomenal. It is gradually competing with MCS and short-term VAD. Early application is the key to success. And VA ECMO is the most economical ECMO because it is a short run of ECMO. Thank you.